Thank you very much. This is going to be what we consider to be the future of lung cancer. This is, though I say it's new for years, it is not that far in the future. Many of these things are already in practice, and you may not realize it, but your medical oncologists, your surgical colleagues would know that these are things which are happening already. So I've got a lot of discussions. This is mostly because of the research I do and various clinical trials I participate in. So what do you consider as future of lung cancer? What are future advancements? So the first thing is we are moving away from picking up advanced cancers to trying to seek out the cancers early on. Then as part of that, lung cancer screening is an important diagnostic way. I talked about lung cancer screening, I'll not elaborate too much on that. Then we'll talk about liquid biopsy. Then, in the current era, when you are defining lung cancer or any cancers by underlying genetic alterations, how do we diagnose these cancers? And what is the role of radiologists in understanding the treatment response and also their various resistance mechanisms? So the first is, when we talk about lung cancer, we're talking so much about artificial intelligence. But before we go on to the artificial intelligence, I want to touch upon radiomics. Radiomics will become part of the artificial intelligence, but before we go there, we have to understand what is radiomics. Then I'll touch about the artificial intelligence. Then how can we improve our imaging reports to add more value to the clinicians? And finally, there is so much of imaging which is being done, it adds to the cost of healthcare. So how do we minimize calculating the cost, at the same time delivering effective care to our patients? So what is radiomics? So when we do our images, all DICOM images, there's a lot of information we can see through our eyes. But these imaging modalities also have a lot more information. So radiomics refers to extraction of advanced quantitative features from medical images. So these are not the features which you can identify by our naked eye. So what are the steps in radiomics in pertaining to lung cancer? The first is you acquire images, like you do CT scan. It could be any DICOM image, right? It could be CT scan, PET scan, MRI, or even a digital ultrasound. Any of these things could comprise the images which are good to get information from. So after we acquire the images, we segment out the lesion of interest. Either it will be the primary tumor or if you are interested in metastasis, whatever it is your region of interest. Then to extract the radiomic features. To extract radiomic features, you have to have the software tools, but the number of tools are out there, and some of them are actually free online. So you can, there's one tool called 3D Slicer, which is free. You can download and use that tool to get more information from the tumors. Then finally, when you get the information from these images, you analyze this data. The data is a lot of data, so it requires some sort of sophisticated tools, statistical tools to figure out the importance of these various features. So after you get this information, you can correlate the imaging features with pathology, with their underlying genomics, and you can also try to figure out what will be the response of these tumors based on these radiomic features. When you talk about radiomics, there are several ways of radiomics. You may not realize we all do some sort of radiomics. When you measure the tumor, it's also sort of a radiomics in a way. So there could be different levels and steps of radiomics. The first step is the basic step is the morphological radiomics. Then you have statistical first order. Then you have higher statistical order radiomics. Then finally, you start using deep learning methods to understand more about the features of these DICOM images. So the simplest on the morphological analysis. We all know that we measure the longest axis. We measure the short axis. We can also measure the tumor volume. But there is more to this than we realize. For example, the compactness of the tumor. What is the surface area of this tumor? What is the surface volume ratio? If the tumor has more surface area, it has worse prognosis. So what is the specificity of this tumor? There are several other aspects which fall under the morphological analysis, which is difficult for us to understand, but the computers have the ability to figure this out. They give you all these values. So we can figure out what is the significance of these values in a particular tumor and how it affects the prognosis. So So the first order statistical analysis is a CT Hounsfield graph where we have the distribution of the number of pixels containing a particular Hounsfield unit and the number of pixels containing that particular Hounsfield unit. So then you plot a graph like this. You can look at these histograms and you can derive several features. Features such as entropy. Entropy refers to the complexity of the structure. So in general, more entropy is present in a tumor, it's more complex. So this is goes with some of the highly aggressive tumors. Then you can measure the kurtosis. Kurtosis refers to the magnitude of pixel distribution. It's a marker for the vascularity of the tumor and blood vessels. Then you can also look at the skewness. The skewness could be the histogram could be skewed towards one side or the other. So this refers to the measure of non-vascular structures. So these are three common things which are used. We are aware of these terms, but there are many other terms. Literally, there are hundreds of those terms. We can also have percent positive pixels, standard deviation, and logarithmic expressions of these various values. That will help you give you more information about the tumors, and we can correlate the significance of these various features with other outcomes of the cancer, such as histology, genetic mutations, overall prognosis. Then nowadays we are talking about more higher order statistical analysis. It is beyond the first order statistical analysis, just beyond the Gaussian-based histograms. We try to understand the relationship among the pixels, so the size, number, distance, angle, and so on and so forth. And now we come up with many other terms such as GLCM, which refers to gray level co-occurrence matrix. You can also have gray level Roman matrix. But the important thing is don't get confused with these terms. These are not that important. Just to understand that there is more information in the images than your eye can see, and you can extract these quantitative features. And these quantitative features, if analyzed properly, can show us the relationship between the imaging features and various other aspects of the lung cancer. We don't have to confine ourselves to one imaging modality. We can use, say, for example, for doing pure energy CT, we can get information from low energy, high energy, or you can get images, data from MR images, or you can combine the features from CT images with the PET images. If you are trying to get information from multiple imaging techniques, then it becomes multi-parametric analysis. So, with that introduction, now we are more interested in figuring out how this will help us. The first thing is by applying the radiomics, and the same application is continuing beyond radiomics with artificial intelligence, we can characterize a nodule. We can tell a nodule is likely to be benign or malignant. So we looked at this, there are several papers out in the literature. We looked at the radiomic features by using a textual analysis back in 2018. Then we could separate out the benign features with malignant features. But the problem is, we can definitely separate out highly aggressive tumors from benign tumors, but it is not so easy to separate out a well-differentiated lung adenocarcinoma from a benign tumor, such as atypical carcinoma, some other tumor like that. So it becomes a little challenging. So aggressive tumors from very benign tumors are easy to separate, but if the tumor is very well differentiated, there will be some problems. But more importantly, these radiomic features will show you some values which are of good predictors for what are a highly aggressive tumors from benign tumors. So we can also characterize the nodule. For example, you've got two images here. One is a squamous cell carcinoma, other is a schwannoma. One is a benign tumor, other is a lung cancer. So looking at these images, CT images, they look pretty homogeneous, difficult to figure out what these are. But then if you do a textual analysis, they have a different signatures. By looking at these radiomic features, you have the ability to say, oh, these two tumors, though they look similar on imaging, they are two different types of tumors. Because their kurtosis value is different, their entropy is different, their logarithmic expressions of inverse standard deviation is different. So this tells you these tumors are not similar, though they may look similar on imaging to our human eye. You can also differentiate pre-invasive carcinomas from invasive adenocarcinomas. We know that many ground glass nodules are pre-invasive cancers. The patients may never have clinically active cancer in their lifetime, but some of these cancers may develop into more invasive cancers. By using these radiomic features, we can differentiate which cancers are likely to become invasive, or more importantly, on these different types of nodules, which are invasive and which are pre-invasive cancers. So we can target our therapy, or we can figure out how soon to follow these patients by repeated CT examinations. So this is a paper we published in Cancer Imaging, where we were interested in looking at patients with multiple ground glass nodules. So we know that many of these ground glass nodules will remain stable for a long period of time, nothing needs to be done. But occasionally one of these ground glass can become an invasive cancer which needs treatment in the form of either surgical resection or radiation therapy. So we looked at this series of these nodules, and we wanted to find out if at the very beginning, very first scan, can we predict which of these nodules become more active cancers during the follow-up period and which nodules remain more dormant or indolent. But it is not that easy. In the very outset, we cannot say which is going to be a cancer, active cancer, which is going to remain indolent. But if you follow for some time, by changing the radiomic features, we can predict which of these nodules is more likely to become an active invasive cancer versus those nodules which remain more indolent. As you see here, this is a nodule and this is a nodule. So this nodule was developing this solid component. So this is becoming an invasive adenocarcinoma. By applying this radiomics, we can figure out which of these nodules are likely to become invasive sooner than just by standard imaging. You can also look at these patients who have got different types of underlying driver mutations such as EGFR or ALK or RET or ROS, and we can analyze them, and we tend to see differences in their radiomic features for patients with underlying EGFR mutations compared to those without EGFR mutations, though they have similar clinical profile. So this is something which helps. But again, what features differentiate varies based on the question you ask. In this case, we found that standard deviation entropy purposes were more meaningful in separating out EGFR mutant cancers from non-EGFR mutant lung cancers. We can also see that we know that some cancers are very small, but they tend to have distant metastasis very soon. There are some cancers which are small and they tend not to have distant metastasis or even lower metastasis. So it is just, we are very curious to see what determines this type of behavior of cancers. Why do some cancers metastasize early? So we ran radiomics on these patients in a particular group of lung cancers. All of these lung cancers had underlying ERAF mutations, and we found that there is a difference in their radiomic features of the primary. The primary tumors are all of the same size, from stage 1 to stage 4. The primary tumor, the peak tumor, was of the same size more or less, but they had very different radiomic features between the patients who had small size tumor with distant metastasis, stage 4 tumor versus the tumor small and did not have any nodal or distant metastasis. So this is how we can figure out. So this is a very exciting field, but it is still in inception. We have to figure out how to use them in future, how to incorporate it into clinical practice. So similarly, you can also, before we start a treatment, by understanding the underlying radiomics of these tumors, we can understand which tumors are likely to have treatment response and which tumors tend to not respond so favorably. So this is also a good thing to know beforehand which tumors are likely to respond. If you understand you have some concept or some idea, then you can actually use them sooner than later, and you will prepare with some of the alternate therapies. There are a lot of major challenges for the implementation of radiomics in clinical practice. Because we are comparing different tumors, the imaging data acquisition should be more or less standardized. So we cannot compare apples to oranges, so we should have the same type of technique. Suppose it is say you are using a I- study without IV contrast, you cannot compare the two with IV contrast. You should do some sort of standardization for what you are going to compare. Then how do you extract the tumor from the images? When you are picking out the lung cancer, say from just in neglected, you should be very clear how to segment out the tumor, whether you're going to manually outline the tumor or use a semi-automatic process or a completely automatic process to extract the tumor from the lungs. Then there are literally hundreds of such radiomics. So we should also understand which tumors, which factors are we going to focus on, and how do you understand the significance of these various features. Then finally, data analysis. Because we're literally talking about hundreds to thousands of features, The data analysis is also very complex, and we need to have a good software to analyze this data. So now we move on to the other component of artificial intelligence. So radiomics will become a part of our imaging features for artificial intelligence. But before we go there, we should understand what is artificial intelligence. When a computer performs a task that requires human intelligence, let's say for example image interpretation. I'm looking at the image and say this is a cancer. The computer can do it. That is artificial intelligence. So that is the simplest way to define artificial intelligence. So computers can do what you can do. Suppose I measure the dimensions of an iota or a tumor. If computer can do it, that means it is performing your task, therefore it is artificial intelligence. But when you talk about artificial intelligence, there are several levels to it. In the current era, we are talking about machine learning. So this type of softwares can not only do what you can do, but they have the ability to learn without being programmed. So they can learn. They learn by themselves, so get better and better. So this is the era of machine learning or deep learning. So this is the current level of artificial intelligence we are in. So when you talk about machine learning, artificial intelligence, we are all afraid. We think that our jobs are being taken away, but that is not the way to look at it. We have to think that this will be an aid to radiologists. It will speed up our interpretation. This will improve your accuracy. We can detect more cancers early on. Then we can also do more quantitative analysis, like I showed you some examples of radiomics. Then the question is, is it a substitute for radiologists? I don't think so, because all said and done, medicine itself is a very different type of science. There is a lot of subjective element here. So the machines are not so good at the subjective element. So we'll still be in the business. These tools will help us to perform it. When you talk about artificial intelligence, there are two components to it. The first is the imaging data. So what all I told you about the CT tachometers, the features we extract, that all come under imaging data. So when you extract the data from the tachometers, we do what is called as computer vision, which involves convolutional layers, pooling layers, fully connected layers. Then you get output from this imaging data. But we also have another important component, that is the tabular data. We also need other details, the patient demographics, age, relevant history, exposure, smoking, all those things. So that is formulated under tabular data. So this are analyzed by feature engineering. Then we use something called random forest, XGBoost, support vector machine. Then we combine all these outputs, then we get the final output. So it involves your imaging data and also the tabular data. So these are the various steps. I'm not an engineer. I am not developing any of this software. I work on these different artificial tools which are being developed. I validate them. So to see how what is the accuracy in clinical practice. So that is what I do. My research is focusing mostly on applications of AI. So when you have this type of data, when you develop this tabular data, radiomic data, you develop a machine learning algorithm. Then to develop this algorithm, first you have to provide some data to the computer. You have to say, okay, this is a lung cancer, this is how it looks like. This is a benign nodule, this is how it looks like. The algorithm will learn, differentiate the features, then it develops a model. Once a model is developed, then you feed new nodules. Now you don't predict whether it's a benign nodule or a malignant nodule. If the model is good, then it separates up. It says, okay, this nodule, what you've given me, is a malignant nodule. This is a benign nodule, based on what we learned from the previous test set. So that is how this artificial learning intelligence, machine learning algorithms work. And if you more feedback you give back to the model, the better it becomes. And they learn by themselves. They figure out where did it go wrong, where it was not correct in their analysis. It learns by itself. So in future, by applying this radiomics and AI, we can diagnose cancers, we can predict the invasiveness of the cancers, we can predict the genotype of the cancer, we can figure out which nodules are likely to metastasize earlier, then we can finally predict the outcome of those cancers. So the other thing is, when we talk about lung cancers, we have to also understand that we're doing early cancers. But every cancer which is detected earlier in the lung cancer screening program does not always result in no mortality. Some patients still die. You treat the cancer early on, but still the patients die. So we have to understand what are the factors that determine the outcome. Is just the cancer or something beyond cancer? Then how can we improve the current reporting, and how to improve accuracy, and how to contain costs? These are also part and parcel of our job. We are diagnosing cancer early on. So for example, a patient who has got a stage 1 cancer, very early cancer, but the patient also tends to have heavy coronary artery calcium, also has very reduced muscle mass sarcopenia. These patients tend to have bad outcomes. For a given cancer stage, identical cancer stage, this is the study we did. So when I did data, we found that for a patient with same stage of cancer, some patients had higher mortality, lower 5-year survival compared to patients who had a better outcomes. So when we tried to analyze, we looked at 3 parameters: the coronary artery calcifications, we looked at sarcopenia or muscle mass, we looked at the amount of subcutaneous fat, the adipose tissue, then we also looked at everything. Then we found that the sarcopenia has a bearing with the outcomes. Patients with early cancer, if they have poor muscle mass, they tend to have poor outcomes. Patients with heavy coronary artery calcium tend to have poor outcomes. So this is something we'll report in the future. So we're just not talking about lung cancer. We also talk about the other structure, other features that may affect the outcomes. Then we are trying to understand how cancers look like. Not all cancers are solid and subsolid. There are also cystic lesions which develop into cancer. So this is something we did not realize before we started doing lung cancer screening. So now we know there are some cysts. They look like enzymatic cysts or metaceres, but they are actually very early lung cancers, and they become aggressive cancers when we follow them. So we are looking at new types of cancers. We know cancers are different types of appearance. In the cancer mimickers we saw some consolidation, which looks like cancer. So there are also cysts which can become cancers. So we are understanding other manifestations, uncommon manifestations of lung cancer. This is going to be the future of lung cancer, understanding different presentations. Then cost reduction. We talked about lung grafts. I said lung grafts gives you probability of lung cancer risk in a given body. But then if you just use lung grafts, probably we are not very accurate. We are doing more imaging studies. But along with lung grafts, if you incorporate other features like age of the patient, gender of the patient, race of the patient, the smoking history, not just the arbitrary cutoff of less than 20 pack years or more than 20 pack years, but if you add more history about somebody who smoked 25 pack years, if you add that information, we can actually more define the lung grafts, and we can subselect the patients who are more likely to develop more aggressive cancers. So by doing so, this particular paper, and this is a citation from Journal of American College of Radiology, so they found that there is a lot of cost savings. We can save up to $72 per patient. So this is the feature, not just lung grafts. We are incorporating with other details. So this is the AI model, which will have more benefits. So now in today's era, we are not talking about small cell, non-small cell. That we still will talk about, but in the non-small cell, we should talk about adenocarcinomas, squamous cell carcinomas, neuroendocrine cancers. But in the current era, we are more interested in underlying genetic mutation. We know that adenocarcinomas, roughly half are KRAS mutations, and there are other type of mutations such as EGFR, AL, ROS, and others. The important thing is, many of these specific mutations have specific targeted therapy. If somebody has got, say, lung adenocarcinoma driven by EGFR mutation, their treatment is not standard chemotherapy. They are treated differently, especially for advanced cancers. So they are treated with specific drugs, tyrosine kinase inhibitors, which has less toxic and it improves the outcomes. So this is what we do. For all advanced lung cancer, it is now mandatory that we check for these type of mutations for which there are specific treatment options are available. So because we are talking about these different types of mutations, it becomes important for us to understand how can we predict the different mutations. So one common thing is we wrote this review article. This is my area of interest, one of areas that I work. We looked at all the patients who are likely to have mutations clinically. These are usually patients who are non-smokers, and they can be, if they are non-smokers, women, and they are Asian origin, they are likely to have EGFR mutations. But these patients are younger males and they are non-smokers. They tend to have other type of mutations such as ALK-related. And we also found that there are some imaging features Like for example, in the diagnosis of lung cancer, we see sclerotic metastasis that we see in thoracic vertebra here and sternum. These patients are likely to have some sort of a rearrangement, either heart rearrangement or rectal rearrangement. So this is an important clue. Right off the body, they can tell the clinician, say, hey, this patient has got this type of mating features, which make me suspect that this patient got some underlying mutation of these types. So they can quickly order these studies, genotyping, so they can start the specific therapy. Because if you think a patient has got underlying genetic alteration that is causing the cancer, you should not treat them with the standard chemotherapy, but you should use a appropriate targeted therapy. Similarly, somebody has got this type of multifocal ground glass consolidated metastases. We want to see what type of cancer it is. They can be mucinous adenocarcinoma, and mucinous adenocarcinoma tend to be KRAS mutations. So if there's a particular type of KRAS that people see, there's an approved treatment for this type of cancer. So this is what you try to do on imaging. So there's some overlap. It's not like every time you can predict. But in a good number of patients, we are able to tell them, hey, I think this patient has got this particular underlying genetic alteration that is driving this cancer. So the importance of making this type of diagnosis is the treatment is different. So for example, this is a patient with EGFR cancer. If you see a multiple innumerable tiny nodules in the lungs, what is called as diffuse lung metastasis or biliary metastasis, and if you think this patient has a cancer, there's a high probability that this patient has got underlying EGFR mutation or alteration. So these patients, with the short therapy, with targeted therapy, they have dramatic response. The response can be seen in a matter of days. So the patient will significantly feel better. Similarly, if somebody has got a ALK-related driven cancer, so again, this type of lung nodule, the lymphadenopathy, lymphatic carcinomatosis, if you treat this specific therapy, the response is also pretty remarkable. So our goal is to identify who are the patients who are likely to have steroid mutations, and in few patients we can suggest to the oncologist, they do the test. In US, it is standard of care for a deep-brain advanced cancer to undergo this type of genetic testing. But in a developing world, because of the cost constraints, it may not be possible. But at least in few patients, you can say, this patient may have this type of mutation, so that will help these conditions. But importantly, the cancer has changed the way it is behaving. Now you treat these advanced cancers with targeted therapy, the response is not forever. They respond for say a period of time, then typically around 12 to 18 months, then the cancer starts coming back. So these cancer cells are quite intelligent, they develop some resistance mechanisms, therefore they can overcome bypass the blockage of the metabolism by the drugs. So there are a lot of resistance mechanisms that are being developed. So as part of my oncologists in the hospital in DH, they do a lot of research on the resistance mechanisms. So as part of the imaging group, part of their studies. So we did for different types of resistance mechanisms for EGFR cancer, for ALK, RES, ROS, and all other things. So because these patients develop resistance mechanisms, if you understand the resistance mechanism that is causing the recurrence of cancer, they can also be separate drugs which can work on the resistance mechanisms. So for example, this is a paper in 2011 when EGFR cancer is being researched. We hear that many of these patients develop cancer. My colleague in medical oncology from the surface, she looked at all these patients who develop resistance, how they develop disease progress after responding initially. Then there are several mechanisms which cause them to develop resistance. The common thing was C790M mutation, MET amplification on apertures. Some of them developed small cell transformation. So this is what they realized. Now we know that this is the underlying resistance mechanism. Now currently in the current era, there is a separate drug which can counter this C790M resistance mechanism. Similarly, thinking for MET amplification, there is a drug which can counter this type of resistance mechanism. So as we understand the disease more drugs will be developed, and as imaging specialists, we understand when the disease is coming back, what type of recurrence, so there's what type of transformation. Suppose say somebody with EGFR cancer is developing multiple new liver metastases, we are worried about this patient developing small cell lung transformation. So somebody is developing say cutaneous lung, it's a good problem if this patient is developing some type of squamous cell transformation. So this is something which we can help the clinicians. So we can biopsy, and intervention is we can biopsy these tissues, understand the underlying resistance mechanisms. In the current era, we don't want to do that many biopsies, but focus is getting a blood sample and figuring out what is the underlying mutation that is driving the cancer. And if the patient is progressing while on treatment, what is the resistance mechanism that is causing this recurrence of the cancer? So we can do liquid biopsy. So this is the several types of liquid biopsies. I'll touch upon this one for one slide here. The cancer cells are continuously being shed in your bloodstream. So if you have cancer, the blood contains these tumor cells. They are being shed. But the tumor cells are so few, it is not easy to isolate them. Or else, the cancer cells can break down and then they can release their nuclear products into the blood. Like for example, DNA, circulating DNA, RNA, all those things. You can get this material. There's a lot of tests right now which are available, commercially available, which are approved by the FDA. Where you can figure out what type of DNA fragments are in circulation, what is the resistance mechanism, and we can make a diagnosis. So in future, we may not have to do that many biopsies. In many patients with advanced cancer, maybe we can do this type of test sample. But then what is the role of imaging specialists? So this is a simple type of test. You take a blood sample, you can do digital sequencing, then you can do analysis pipeline, all those things. Then you get various types of tests, you can do various components of the test. But we realized that when I was doing this test, sometimes the blood testing was useful, sometimes it was not useful. So they were curious. So we had a follow he and I, in collaboration of our oncologists, we looked at all the patients where blood sample was good enough to determine the genetic analysis, and other patients where the blood tests were not useful. Then we found that patients who have got advanced disease, which is confined to the thorax, the blood cells, the blood is not a good way to look for the DNA product, circulating DNA. If the disease is outside the thorax, there's a very high success rate of detecting the tumor circulating DNA in the blood sample. So this is something which is very useful. So instead of doing a costly blood sample, we can say that okay, this patient has disease confined to thorax, so maybe the blood sample just may not be that useful. Instead, we can biopsy one of these lesions in the lab to determine the resistance mechanism or make a diagnosis. So that is something we can do. So as things are evolving, the role of imaging is also evolving. We should understand what the clinician wants so we can tailor our needs and focus our interpretation for their needs and requirements. So I touched upon before. So along with lung cancer screening, we have integrated blood samples so that we can detect these cancers early on. That is something which will be done not so distant future. There are so many clinical trials right now which are going on, which are looking at the blood samples to figure out what the biomarkers. Thank you very much.
Thank you, Dr. Parsi, for such a comprehensive overview of the new developments in the evolution of lung cancer. And we appreciate your time and effort for presenting 3 lectures in one session. And thank you so much.
Now is Dr. Mohammed Jamal, as Assistant Professor of Chest Medicine and Bronchoscopic Management of Lung Cancer.
Alhamdulillah.